Okay, so opposite end of the spectrum of the tree, again, is the spinal trauma associated with neurologic complication and injury, ranges from 15 to 30% of the same injuries that we were discussing. And again, this is a high rate of morbidity and mortality. Won't go through the classifications, but basically surgical management for these type injuries involves several principles, including basic decompression, whether or not front or back, fracture reduction, and adequate stabilization. And I think that while there is surgical preference, you really do need to have an arsenal of approaches to treat these patients. Not every hole is the same, and not every hammer needs a nail. So surgically, I think when we consider those posterior fusions alone, we need to assess the stability again of the ligamentous complex and whether or not there will be late progression or kyphosis. Now, if there's an unstable fracture pattern and we're going to lead to decompression, are we going to further destabilize it? And in complete neurologic injuries, I think posterior approach provides a better option. Anterior decompression, usually involving corpectomy and strut grafting, is again all based on stability and the ability to mobilize this patients. What we need to consider also is that our conventional open approaches have added trauma to the patient who has suffered blood loss and multiple other injuries leading to higher rates of infection, and then approach-related mortality, especially with removal of the diaphragm and mobilization of soft tissues. And so I believe there'll be a talk on some of the more less invasive technologies, including thoracoscopic, the percutaneous screws that I'd mentioned, and the use or not of cement. So when do I prefer posterior approach alone with instrumentation? I in general like with acute neurologic injury to go from the back just to open the canal in most cases. But the considerations obviously have to be, again, whether or not the anterior column will be stable and how much comminution there is. Will the patient need a secondary surgery? So posterior laminectomy allows for direct decompression of those posterior elements. It also gives that great ability of stabilization with the pedicle screw constructs. And meta-analysis looking at instrumentation has showed that 2 levels above and 1 level below provides the best biomechanical approach. This is a case of a 26-year-old female who was 6 months pregnant. She was struck by a motor vehicle. I would draw attention to filiodel. This is a case where there's a fractured dislocation at the T4-5 junction. And if you can appreciate this is the superior articular process. This, to me, is an ideal case for a posterior decompression and single-level instrumentation as quickly as possible, as she has unilateral deficits and fetal monitoring and blood pressure needs to be well maintained throughout the procedure. This is a 64-year-old male with a burst fracture and unknown age with an acute component of an L5 compression fracture. This obviously puts some consideration on what to instrument, how far to instrumentate, and I chose to do this again from an all-posterior approach while trying to avoid any involvement of the L5 segment, but consideration of placement of cement at that level. Essa é minha favorita. Paciente estava cagando em cima uma ponte. E quando ele tem as cuecas no chão, o trem veio e bateu ele na rua, no rio. Desculpa. It was winter, so the water was freezing and neuroprotective. He made me famous. But he suffered a L2 burst fracture. among other injuries, and there was unknown status of his he had unknown neurologic status at this point, based on the fact that he was again hypothermic and obtunded. So this is another case where I prefer the posterior approach. There is good apposition of the fragments, and I believe the anterior column is stable. So AO suggestions for anterior alone usually refer to without neurologic deficits and posterior ligamentous injury. These patients usually can have incomplete deficits. There are retropulsed fragments with or without severe canal compromise, anterior comminution, or kyphosis of 30 degrees. I find it difficult to assess that kyphosis of 30 degrees since most of these patients can't stand up. And so there's some element of our own knowledge as to whether or not there's 30 degrees there. But again, that would be our concern long-term for progressive kyphosis, is whether or not this will lead to pseudoarthrosis or non-healing and risk any stresses based on a posterior approach alone. Now, my preferred approach to anterior would be a placement of a cage as such with short segment instrumentation. But I do think there are a lot of significant pitfalls to the placement of these cages, and I always stress the fact that there are three things that we need to identify with these injuries, and that is there an unidentified injury to the end plates of which we're putting these cages in? As well as over-distracting these segments. I prefer to leave it slightly kyphotic. And the last thing is the edges of these implants, especially one that I'll show you soon, can have a cleaving effect into the end plate itself and lead to settling. I think also in osteoporosis, there's the option for cement augmentation, although I'm not one who likes to overuse cement. Now, looking at the anterior and posterior approaches, we do know that this long-term has better angular protection for these patients. And they also have the same level, equal if not even better, improvement of neurologic outcomes. Again, this was recently published in JNS Spine, and this is kind of the approach that I really like to take. It's a 48-year-old male with a fall from height. He has a 3-column injury with retropulsed fragments, and he also has a coronal deformity. I do like, for these type injuries, to obtain 3D CT images and kind of get a perspective as to where I get them before and after placing the instruments. But from the far lateral approach, I think you get excellent visualization, and when you can get as I like to refer to that as the tuberon, you can do your corpectomy very quickly with large instrumentation through quite an accessible portal that would be using the lateral retractors. And getting a good cage height in there is also possible. There's a 19-year-old male with a L3 burst fracture. He has complete motor loss in the lower extremities. He's taken for acute placement. Again, the cage is fine intraoperatively, but getting those things to be and stay where you want them is a challenge. And so, with all the discussion, we say that the times, the technologies, the styles change, but do the complications change? I think the complications stay the same. And I like to. This is the article discussing the short segment instrumentation as pertains to the load sharing classification system. And I like to point out the second highlighted segment, that long segment fracture repair is used for patients with unpredictable post-operative compliance. This is a 58-year-old male who was an alcoholic. He actually ran over a 2-year-old child. And he had complete neurologic deficit with this burst fracture, retropulsed fragments. And this looks great. I thought I got this large cage in here. Was able to decompress the canal adequately. He had complete neurologic improvement. And then he continued his drinking, and so he fell and he dislodged the posterior screws. So he ended up with this. As the cage began to settle, I gave him long instrumentation. He continued to drink. He fell down the stairs. And if I didn't take this x-ray with him leaving the hospital, I wouldn't have proof that I didn't just cut open his back and throw some screws and instruments into it, as he had complete dislodgement of the instrumentation for the progression. So what does he get? He gets more surgery. So lesson learned by not remembering the particulars of those papers that have kind of led us to where we are. Thank you.